Okay. So we were talking about pain management, and this section is going over the opioids, which is probably like the #1 class. Um, and again, this is going to be a very special. So fentanyl is a Schedule 2. So the Schedule 2s that you needed to know were morphine, hydromorphone, fentanyl. But the very unique thing to know about fentanyl, it pretty much has to go IV because it really only lasts about 30 minutes. If you give it in the muscle, you'd have to give it to them like every hour. So you could you could theoretically give 1 injection of fentanyl IM, but if you were using it for long-term pain control, most of the time it's given via a CRI. So, a constant rate infusion. A lot of times they might be pre-medded with like morphine or hydro, and then they'll hook up fentanyl and maybe run it usually via a syringe pump. So they'll do like regular IV fluids. They might hook up fentanyl and drip that in at a constant, like low infusion. And the main reason to do that is to lower your inhalant. It lets you run a lower MAC, and that's an advantage. I know it says IM SubQ epidural, but again, it just doesn't last long, those routes. You can also do that neuroleptal analgesia. You could do fentanyl, midazolam to induce anesthesia in a critical patient. And it is reversible, but I am going to later talk about the patch, because a fentanyl patch is another thing we can use, and I will talk about that. One to get used to. A lot of clinics, you guys will probably use a lot, well, we use it at school, and a lot of clinics use butorphanol. The trade name is torbugizic, so sometimes when they say, let's Torb this patient, a lot of times the slang for your butorphanol is Torb. It is an opioid agonist antagonist. So if you remember, there's agonist, antagonist, partial agonist, full antagonist. So this group is not fully reversible because it's not a pure agonist. So it's partially reversible. It stimulates kappa, but it blocks mu. So you don't get the full benefits. So it's not as strong of an analgesic as the other, the agents that I just talked about. Even though it says produces less sedation, it does have some decent sedative properties. But again, the main reason I've had some patients that were older, debilitated, sometimes really sick cats, and we need to do a radiograph, or we need to do something very minor. And sometimes 1 injection of Torb, you'll actually get a little bit of sedation, but primarily it's an analgesic. Now, it is a schedule, it says a Schedule 3 here, but it's gone between a Schedule 3 and a Schedule 4. I believe right now it's a Schedule 4. So it doesn't have abuse potential, and that's why a lot of clinics like to carry it, because, people aren't breaking in to steal Torb. And if they do, then they're not very smart. It's not a high abuse drug. But what I want to mention is one unique way we've used Torb is I will take 1 ml of butorphanol and I can mix it in 10 ml of saline to kind of dilute it out. And if I have a dog that's respiratory depressed, like on fentanyl or morphine, any of the pure agonists, what we've done before is we've pushed a little bit of this diluted butorphanol, and it's enough to reverse the respiratory depression, but it doesn't fully bring them out of the sedation. So even though it's not a pure antagonist, it has antagonistic properties. So it's kind of our anesthesiologist at Purdue, we did this technique, and it's pretty cool. I kind of start pushing this diluted butorphanol very slowly, and then when their respiratory rate or their depth increases, I stop giving it. So sometimes it's enough to reverse a little bit of respiratory depression. Um, and I will tell you, it's not good for bone pain. So this is more like soft tissue pain, maybe superficial wounds. I mean, it's used a lot in spay and neuters. So it does give you, we use it pre-anesthetic. We use it as part of their protocol. It can be given IM, IV, SubQ. It does have a tablet form. So some clinics will carry butorphanol tablets. The interesting thing, and you can put a note somewhere in your notes, it's actually a cough suppressant. So sometimes if we have a really bad kennel cough case, we have prescribed butorphanol tablets. The problem is butorphanol is fairly expensive. It does not have a generic form. I feel like it should be pretty close to getting a generic, but it is pretty pricey. So if you're going to send it home as a cough suppressant, it's not going to be cheap. But I've seen some doctors prescribe butorphanol tablets. Very rarely do we send home butorphanol tablets for pain post-op just because of cost. But it is in a tablet form. But the tablet form isn't used pre-op. It's typically not used in the hospital. A lot of times they're sent home with the owner. And again, here it's, I think, currently a Schedule 4, and that's what I want you to know. Now, buprenorphine is considered a partial agonist. So this is the other drug that you will use at school, and a lot of clinics carry buprenorphine. Some people call it Buprenex, which is one of the trade names it goes by. Some people call it Bup. So there's Torb and Bup are kind of the nicknames that it's given. But it is a partial agonist, can be used in dog and cat, and you can do the same partial reversal trick. You can dilute a little bit of buprenorphine diluted in saline and push it just like I talked about with the butorphanol. But one I want to tell you, this is the opioid of choice in cats. I'm always trying to give you guys key, unique information about drugs. And if, there's a couple different reasons it's used in cats and a lot in exotics. It's used in exotics quite a bit. Number one, you can use it orally, but I guess I really need to change this slide. It's not given orally in food, or we don't want them to swallow it. It needs to go either sublingual or buccally. Actually, I'm going to type that because that's something you need to know. I don't know if I can actually type. So you can give it sublingual. Now, they did studies where they gave cats SubQ injections, and they gave some cats sublingual or buccal buprenorphine, and then they measured their plasma levels, how much drug do they have in their system, and it was equal. The cats that got it SubQ had just as much in their system as the sublingual cats. So the nice advantage is this a lot of times is sent home after maybe like declaws or extractions in a cat, maybe after surgery. And what you guys will do is I usually draw up their dose in little 1 ml syringes, the tuberculin syringes, and you take the needle off. We have these little caps, these little plastic caps. I don't like to send home needles with the owner unless they have to inject it. But if you take the needle off, and a lot of times I just show the owner, and I'm big on client education, especially because you guys are almost done and you might be meeting with clients on your externship, or whenever I give a client a medication, I first of all want to show that, I usually bring it in the room, show it to them. If I want to demonstrate it, you can always draw up a little bit of water or, saline, or and so, because if the cat has already gotten the medication, you know, and they're not due for another dose, I want to make sure the client's comfortable understanding how to give this. And you have to explain to them, don't put it in the food. When people hear oral medication and cats, a lot of people like to squirt it on the food. Well, number one, it has to be absorbed through the mucous membranes. It's not absorbed in the GI tract, it's absorbed through the mucous membrane. So if they squirt it on food, they're not going to get their dose. So that's the number one thing to tell owners, is you can't put it in the food. And the other thing is, well, it doesn't need to be refrigerated. You don't want to really mix it with anything else. It can be given with other pain medications like Onsior or Tramadol. So it can be given at the same time as other medications. Sometimes what I'll do, say the client comes at 4 o'clock to pick up their cat and they were due for their next dose. Sometimes I will give it to the cat in the room with the owner, and then they don't have to worry about that dose, you know. So sometimes I'm like, do you want me to give it before you get home? It's just kind of a nice thing to do for the client. The one thing is, you can use buprenorphine in dogs. The problem is the concentration, it's usually, I want to say 0.2 or 0.3 mgs per mil. And if you had like a 50, 60 pound dog, it would get a lot of buprenorphine. It gets expensive. So it's not typically used in dogs. It's very effective in dogs. It's a cost issue. So again, it's used a lot in cats and exotics, not a lot in large animal, but again, they can get it. The other thing is, this is something important. It has delayed onset of action and longer duration. This can last up to 6 to 8 hours after a SubQ injection. And if the owner is giving it sublingual, we usually tell them to give it every 8 to 12 hours. Well, so they might be able to give a dose in the morning and a dose when they get home at dinner every 12 hours. So it has the longest duration of action. So I've told you the shortest duration is fentanyl, because that's only 30 minutes. The longest duration is buprenorphine. But again, it's not as effective for like the deep pain, bone pain, but soft tissue pain, it's a good option. I know it says Schedule 5, and it's a Schedule 3. It is a Schedule 3, which still has that lower abuse potential. So it's not, we don't usually worry about people stealing buprenorphine either. Most of the time people want the morphine or fentanyl or things like that. Now, these opioids can be given IM or SubQ. Sometimes we give them IV if they're extremely painful during surgery, but the benefit to giving IM or SubQ is you get the longer duration of action. So let me give you an example. When we use morphine and hydro, those last about 4 hours. If they're getting it, IM or SubQ, we usually give it every 4 hours. If it's fentanyl, it's in an IV. And if it's buprenorphine or butorphanol, is every 4 hours. If it's buprenorphine, it can be every 6 hours up to every 12 hours. It kind of depends on the patient, their response to it. Now, some of these agents I've explained can be used in the joint, and anytime it's articular. Intra-articular is inside the joint. You put the needle in the joint and infuse it. And there is the patch that I'm going to talk about. So here are the big side effects that I've talked about with the medications. Now, I did tell you fentanyl, if I go back, is a very potent respiratory depressant. That's probably the big thing we worry about. You got to be very cautious. If we're using fentanyl, I'm always paying really close attention to their respiratory rate and also how deep they're breathing. Because if they start getting really, really shallow breaths, if they're slowing down, plus they're not breathing deep, it can be that they're getting deeper under the fentanyl And, you know, if you're giving it CRI, then we would turn down our fentanyl. Maybe we're giving too much. And so I've talked about these side effects. Now, the intravenous infusions, if you're going to do a CRI, and a lot of clinics now are going to CRIs, especially if you're working in an advanced, you know, surgical field. So morphine and fentanyl are the most common. Morphine, you can do a morphine CRI, or we can do that CRI, I called it MLK, which is morphine, lidocaine, and ketamine, and that's given as a CRI, and you're giving low doses of those continuously. Normally when we do a CRI, you have to make sure we don't start with the CRI right off the bat. Usually they get a loading dose in their pre-med, or they can get a loading dose in surgery and then you start the CRI. Because remember, you got to get plasma levels. When you do a CRI, you're doing lower doses, but you're giving them continuously. But again, if their pain level is here and you're starting with a maintenance CRI, we have to kind of meet analgesia first. So that's the purpose of a loading dose, is to get up plasma levels. And then normally, you know, when you give one injection IM, plasma levels are going to start to go down. Well, the goal is you get them up with an injection, and as they fall, you're starting the CRI. So what we're doing is we're trying to plateau or keep a continuous infusion via a CRI so that those plasma levels aren't dropping. And you can, you know, some clinics use a syringe pump and just hook up one drug in the syringe. Sometimes like MLK is mixed with a bag of IV fluids like LRS or Plasmolite, and you add a certain amount of morphine, lidocaine, and ketamine to that bag. And then we run it at like 2 mg per kg per hour, 4 mg per kg per hour. You would have a rate. Now, let me bring up an important point, and I feel like I'm blasting information at you, but a lot of times these dogs in surgery are getting a bag of IV fluids as their IV fluid support, and that bag is run at their surgical fluid rate. If they're getting a CRI, that is not their fluids for surgery. That's typically another bag of fluids, and that's run at a much lower rate. So one of the keys is if an animal was to need a fluid bolus during surgery, say their blood pressure was low, and all you guys have been pretty good about like give a fluid bolus to kind of boost their blood pressure. You don't want to do it with the CRI bag. I usually, if I have 2 lines going to a dog, a lot of times in critical care, a dog might have multiple things running to its IV. I always mark the lines and I mark my IV pumps. So if I go to turn one up, I don't want to turn up the wrong one. And that's, you know, I just take a piece of tape and I write CRI, LRS, blood, you know, whatever I'm infusing. It's a really nice tip to mark your fluid pump. And I usually take a piece of tape right at the line going into the catheter, so I know which line is for which fluid, just like a little tip. Now, if you're doing intra-articular, morphine, and one thing that I want to mention is that, if I've not mentioned this already, morphine has 2 forms. So morphine, you can get morphine with preservative, which, you know, the bottle is kept at room temperature, and it's a multi-dose vial, meaning you can pull out of that vial for multiple patients. There is a preservative-free morphine. Now, preservative-free, some animals react to the preservative. And when we're going via epidural, or if we're going intra-articular, those are spaces we don't want a reaction. We don't want infection. Those are very hard. If you get an infection in the joint, or you get an infection around the epidural space, which is going around the spinal cord, those are very hard to treat. So a lot of times when we do those injections, we use the preservative-free morphine. And usually those come as, sometimes they're a glass vial. so you have to crack the vial. And, so you're not trying to inject back into that bottle for multiple times. So I do want you to know there's 2 forms of morphine, and I have a note about it on the next slide. But a lot of times they will dilute the morphine and they will infuse it, like they'll close, like when we do a cruise ship repair. When they close the joint capsule, a lot of times I'll hand the doctor a syringe sterilely, and I have to kind of hold the vial, and they draw it up and they infuse it into the joint. But it can give 8 to 10 hours of analgesia because there are receptors, pain receptors within the joint, and it will treat pain. It's an added analgesic benefit. Morphine epidurals are common. Now, an epidural, I'm going to get into how to do an epidural, but when we do this, it's at the lumbosacral junction. It's L7, S1. If you remember from anatomy, I hope y'all do, the spinal cord ends at about L4, L5. The spinal cord starts to narrow, but at the base of the spinal cord, you have roots of peripheral nerves. When you inject an epidural, you're not injecting it into the spinal cord. You shouldn't be near the spinal cord. If you're at L7, S1, which is the 7th lumbar vertebrae and the 1st sacral vertebrae, that space is behind the spinal cord. But when we infuse the epidural, we're kind of numbing all those nerve roots that control the back limbs. So epidurals are great for fracture repair to the back leg, perineal surgery, like if we had to work on the vulva, if you had to do something to the tail. You can even use epidurals for abdominal surgery because you'll get some abdominal numbing, you'll get numbing to the back legs. But here is the note: preservative-free morphine. Sometimes in large animal, they'll add an alpha-2 to the epidural, like xylazine or romifidine. So there's some, but again, hind limbs, abdomen. Now, caudal thorax, when you do an epidural, you can push it that far up the cord if you add more drug to your epidural and if you push it faster, but we don't want to paralyze the thoracic muscles. So there's a little bit of technique to doing an epidural. Most of the time when we've done them, we're using them for hind limb, back end procedures, not typically going up the thorax. So I'm going to skip over this because I'm going to get into epidurals when we talk about our other PowerPoint. Now, I want to talk about transdermal fentanyl. So fentanyl comes in a patch, and if you've seen like a nicotine patch, or people use fentanyl patches, it looks like a little clear square sticker. And if you look at it, it has a little pouch and it has this gel in it, which that is the fentanyl. And when it's attached to the skin, there's a sticky side. And when you put it on the skin, it's going to be a slow release of fentanyl over an extended period of time. Now, we have to, in animals, obviously a challenge, they have fur. So before we put a fentanyl patch on, I usually clip a square. Sometimes we put them on the lateral thorax. Sometimes I put it on their back. You have to put it on a place where can an animal turn around and clean or groom themselves. So the problem is if you put it over near their tail, a lot of animals can turn around and reach, but they might not be able to get in their shoulder blades, and you want to get in a place where you have good contact. They do come in these different sizes. They go in micrograms per hour. So there is a calculation. The doctor will figure out which patch. We did carry all 4 sizes at VCA. Some clinics only carry a couple sizes. But I'll give you an idea. In cats, sometimes we would calculate they'd only need like 12 micrograms per kilogram. The problem is you can't cut them in half, because if you cut them, you're going to open up the fentanyl pack. I had a doctor once, she folded it in half. So only half of the patch stuck to the animal, not the whole patch sticking to them. So there's some different techniques you can do to adjust these. Yes, and I'm going to get into that, Bethany. What affects the absorption? It's hugely variable in animals. The problem is, well, I'll bring it up for a minute here. When you look at everybody's skin, people, is basically the same. I mean, as you get older, your skin gets thinner. So older people have thinner skin. But let's think about dogs. Let's think about a Shar-Pei versus a Shih Tzu. Shar-Peis have a very unique, well, first of all, their fur is god-awful, and their skin is super thick, and they have folds. And then I think about like Shih Tzus and Poodles have very, very thin skin, or Bulldogs have thick skin. So thickness of skin is going to affect absorption and contact with the skin. So you have to clip, when we clip a square. Now, I feel like I hope you're absorbing all this information, because this is going to be important for the test, this verbal stuff that I'm telling you. Number one is you have to also talk to the client, because some people are very, very sensitive about shaving a patch of fur for these, when we do an epidural, they're going to have a square of fur shaved over their lumbosacral area, where on their lateral thorax, they might have a square of fur missing where we put a fentanyl patch. But I've been yelled at by enough owners over the years of like, you didn't tell me that, or you didn't say this. So you definitely want to make the owner aware that if the doctor is thinking there's a fentanyl patch, giving the owner a heads up. Now, most reasonable owners, if I know that that's going to give my dog pain relief, their hair will grow back. The only thing I worry about is sometimes hair grows back a little bit different consistency. But for the most part, it's going to grow back. This is temporary. My dog is not a show dog, but sometimes you guys will be treating show dogs. And, we had an Afghan hound that came to my clinic when I was in Chicago. And this was like a champion Afghan hound. She did shows, and that dog, beautiful coat. I mean, but she was psycho about what we were doing to her dog and what it was going to look like. So it was written all over the dog's chart, like show dog, don't shave, call owner first. So there has to be good communication when we're doing these procedures. I'm trying to help you guys avoid situations I've been in that get uncomfortable. But thickness of skin, where you place it, which can relate to thickness of skin. How well did you clip the fur? So normally what I do, when I clip their fur, I'll take an alcohol swab and I'll wipe the area, because that'll get kind of like the sebum off the skin. It'll get like the little fine hair, and then I fan it dry. You don't want to wipe it with alcohol and stick this, it will not stick. So after you shave and after you swipe with alcohol, I usually take something and kind of like fan the area, and then I feel it. Is it dry? When you put it on the skin, I'm going to give you another tip. A lot of the adhesive, like Zonus tape, if you put in a catheter and you hold it with your hand, the heat in your hand helps activate the adhesive. It'll stick better. When I put a fentanyl patch on a dog, and you have to wear gloves because it can get absorbed in your skin, and so usually you have to wear gloves, but I will lay my hand over the patch for like 3 or 5 minutes if the animal will let me, because the heat will help activate the adhesive and help it stick to the skin. And sometimes we'll even put a bandage over it. We'll sometimes put like a little wrap over the area to help it stick to the area. Now, it is long-term administration, similar to IM hydro or oxymorphone, which are almost identical. But this is key. it does not kick in for 12 to 24 hours. That's what I want. I know it says like 4 to 12 hours. Cats have thinner skin than dogs overall. So in general, it's going to kick in faster in a cat, but it's very unknown how long. But on average, when we put this patch on, we have to do something to bridge. Again, remember, I think I've already mentioned this. Fentanyl patches are not good for a pre-med because if you put them on the day of surgery, they're not kicking in. So a lot of times, like we used a lot of fentanyl patches, unfortunately, in oncology because these dogs had a lot of pain with cancer, and we would put it on knowing that we were giving other meds till the patch kicked in. So you have to supplement with other NSAIDs or, tramadol, gabapentin, hydro injection, some type of other pain until this kicks in. I do want you to know they last for about 72 hours. So a patch is going to give you, let me put a note about that on here. So for example, this is a Monday, 8 a.m. If I take my dog in at 8 a.m. and he gets a patch on, by 8 p.m. tonight or 8 a.m. tomorrow morning, it's gonna really start kicking in. Let's say 24 hours. So tomorrow, he's gonna have analgesia for all of Tuesday, all of Wednesday, and up until Thursday night. So it's gonna give you about 3 days of analgesia. Now, we had a case where a dog had a jaw tumor, and what that guy would do is that third day, he would come in and we would put a new patch on the third day, because when that third patch is wearing off, or when that day 3 is wearing off, the new patch would already be starting to kick in. So we had kind of a system as he would come in and get a patch, about day 3. So it's a good for like heavy post-op pain from trauma, burns, cancer, painful abdominal, deep, severe pain is what they're good for. But you have to watch for pain. So I told the owner, because if it didn't work, like if your dog is reluctant to lay down, not eating, painful gait, you should see some relief. So this goes back to, how do you know an animal's painful? And, a question like this, I could write half a test on fentanyl if I wanted to. It's like, what do I tell the owner? How do I know it's working? But this is key, guys. You got to highlight this. What are the side effects? Because how often have I been hammering home to you, you are this point of client education. How do I know my animal's having a bad effect from fentanyl? Well, the 2 things I look for in dogs is ataxia or sedation, because fentanyl patches are not supposed to really, now the dog might be more calm and comfortable, but if they're actually sedate, like I'm calling my dog and they're not getting up from sleeping, or when they get up, they look like they're drunk. If they're ataxic and they're walking funny and stumbling, they could be having an overdose from the fentanyl. The other thing is respiratory depression, and I need to put this on here, but the big side effect I told you guys with fentanyl is I teach these owners how to do a respiratory rate. And you never want to assume, some owners are like, oh yeah, I know how to do that. Or if they're a nurse, they'll always tell you, oh, I'm a nurse. And I still explain it to them because, people are different. But if an animal is going to have a deep effect or an overdose, we worry about respiratory depression. So I give them, again, my cutoff is about 6 breaths a minute. I don't really like them lower, but if you watch your dogs, even your cats at home, how often they breathe. I mean, Bo breathes about 4 or 6 times a minute when he's sleeping without any drugs in his system. So, I have kind of an idea of his normal. That's very normal for him. So give them an idea of what to look for. Do they have blue gums? Do they have a blue tongue? Are they not breathing enough? Because you may have to remove the patch. They may have to get naloxone. The problem is when it's getting absorbed through the skin, when you remove the patch, it's going to help. You're not completely taking it away because some has already been absorbed systemically. So one thing that I want you to know too is heat will increase the amount of fentanyl absorbed. Why? Why does heat affect fentanyl absorption?
I
Well,
would guess
because
like those blood vessels dilate with the heat and then absorb more of the fentanyl.
It's like a wick and a sponge. If an animal, and this is key, is if they have a fentanyl patch like on their thorax and they were like laying on heat, so no heating pads, no hot water bottles on the fentanyl patch. Um, you know, if they have a fever, we may have to say, animals that are febrile, their vessels are more dilated. Anytime the vessels under the patch are going to be dilated, they're going to absorb more fentanyl. So, you have to wear gloves. And the other thing I worry about is if they were at home, are they laying in a sun, like my dogs like to go on the stair landing when the sun comes in, and it's pretty hot. Like I go up and pet them or I sit in the sun with them a minute. I'm like, wow, it's kind of like hot right here. So if they're laying on a heating register at home, if they're laying in the sun at home, I tell owners this. I'm like, if they have a fentanyl patch, you don't want to let them buy the heating registers. You don't want to let them lay in the hot spot in the living room. It's going to increase the absorption. They have to know that. And you're going to see the worst side effects if it's applied to heat. The other thing that you have to worry about is because people can be idiotic, is there is a report of someone dying because they took off their dog's fentanyl patch, opened the patch, and tried to inject themselves with the fentanyl, which people just disgust me. First of all, you're taking the pain medication from your animal. So I worry about, first of all, number one, you hope the owners won't do that. The other thing I worry about, ask them, do they have kids in the house? Because you don't want kids going, oh, look, Fluffy has a sticker on Fluffy. Oh, look at this sticker. I want Fluffy's sticker. So kids cannot contact it. Normally, what we like to do, so at BCA, we have a form that they sign when we have an animal with a fentanyl patch. So we have a sheet that goes, they have their discharge papers, and then they have a separate sheet about the patch that goes over all these instructions. But normally what I do is I write the date and the time when the patch is supposed to come off. So there's like a little spot where I can, so for my dog, if it was put on today, it's good for Tuesday, Wednesday, Thursday. Sometimes Thursday, we usually try to get the owner to come back in to have the patch removed. If they remove it at home, some doctors are okay with that. It's just up to your doctor or your clinic policy. If they take it off at home, I tell them to flush it down the toilet. If you put it in a trash can, you worry about an animal. My dogs get in the trash. Could they ingest it? Could a kid go in the trash and be like, what's this? Oh, yeah. There's a lot of variables that you have to think about. So obviously the best option is they come to the clinic, we take it off, and we dispose of it. If they're at home, I just tell them they need to flush it down the toilet and make sure that they don't touch it. Now, the top of the patch, the fentanyl comes out through the sticky side that's sticking to the dog. So if you have, theoretically, you shouldn't really be able to touch it on the outside and absorb much fentanyl. But we worry, what if an end got folded over? I just tell people not to touch it. That way there's not, some risk that something happens. If it gets cut or opened, they need to come back, either have a new patch put on, or we dispose that one and give them other medication. Are there questions about fentanyl or anything I talked about with the opioids? Okay, well, I will start with the non-steroidals tomorrow.